Our next speaker is Dr. Waleed Abou Samra. He will talk about the impact of ocular surface disease on refractive surgery.
Thank you so much for inviting me in this prestigious Congress, and special thanks to Professor Ahmed Wanem, Dr. Ashraf Armaya, and Dr. Amri for invitation. I think this subject needs 80 minutes, but we will summarize as we can. The ocular surface, it is not a simple way, but I think it's a complex biological structure it's responsible mainly not for corneal clarity only, but for the stability of the vision and for all protection of the eye against microbial and mechanical insult. Ocular surface disease, or OSD, it's not only a tear film problem, it's eyelid, eyelash, conjunctiva, cornea, and also limbal stem cell. And again, it is the egg from the hen or the hen from the egg, so it is a multifactorial disease. Is it dry eye the cause of OSD, or OSD coming from dry eye? So it is a multifactorial disease that can result in symptoms and signs lead to tear film instability and potential damage to the ocular surface. And I think that's all that we believe about this current triggers for the dry eye disease. It is not only a local factor, but all the systemic factors and environmental factors. So the most important point is to break this cycle, because this cycle, when it is going into a visuous way, that's of course that's if you have local irritation or systemic diseases or environmental factor, and these circles it's go and lead to more and more OSD. I think we believe that it's more than 15% of the cases in our clinics, it's going to the ocular surface disease, affecting the night vision, reading, computer, watching TV, and the patient is always complaining. Even the American Society of Ophthalmology say that it have a psychological impact. It looks like angina pectoris. We have many diagnostic tests of dry eye, about the prick uptime test and the fluorescein and the Schirmer test. Also the marginal tear meniscus, which is very important to be 0.2 to 0.5 millimeters. Lepkov, of course, the lid parallel conjunctival folds, which is very simple way in clinical manner. And of course, that's the new technology of myopography. I think the impact of a dry eye on the cornea, it's from mild to wild, from very mild affection of the cornea, like superficial punctate keratitis, to very disaster cases with corneal opacities and even vascularization. And this is the case of recurrent corneal OSD problems leading to recurrent affection of the cornea and epithelial deficits. Also, one of the most common causes, the mucus fishing syndrome, and the abuse of the topical anesthesia, especially after a painful procedure like cross-linking or PRK. One of the most common causes of OSD also, it is toxic meticomatosa, or the toxic reactions of the cornea. And I believe most of the patients coming to our clinic with many eye drops led to excessive toxicity of the cornea. So the first thing is to stop all this treatment and to go to the just lubricant treatment. Impact of dry eye on corneal topography is very important, although the pentacam is the least affected by the dry eye, but it's still making the hot spot syndrome. It looks like keratoconus, and it's very important that's to take the pentacam when it's completely that lubricant eye. It is not for dry eye to give this misleading pentacam. I think it is a hidden weapon in all refractive surgery, because sometimes come to the patients unsatisfied, even if it's 6x6, 20/20, it's very good vision, but the quality of the vision, and the patient is always complaining. So I think this is a hidden weapon in all refractive surgery. And I think a prevalence of the dry eye after refractive surgery, it's maybe more than 50% of the cases, even after 3 or 6 months, and sometimes it's longer. So the impact of refractive surgery in precorneal teeth film, I think the laser carries the greatest risk. It may carry more than 50% of the cases after 3 to 6 months, and 90% of the cases in the first week. And this is LASIK versus a SMILE. I think it's very difference between both techniques. And maybe this is more clear in preoperative and postoperative nerve endings that can occur, the regeneration occur firstly in the PRK and the SMILE in comparison to the LASIK. Although that it is debatable case, because some literature say the SMILE and the femtolasic have the same result of nerve endings regeneration after 6 months. So preoperative patient examination is very important for dry eye, even by Schirmer dry test and all tests that's prescribed clinically. And we should obey and respect all the contraindications. One of this is dry eye symptoms before going to refractive surgery. Preoperative optimization is very important, and one of the misleading also diagnosis in MGD or meibomian gland dysfunction, which is very important to be treated before refractive surgery, either by artificial tears, topical azithromycin, tetracycline, swabbing of the lid margin, hot fomentation, IPL, massaging of the eye. Operative consideration is very, very important in cases of dry eye syndrome. So the LASIK is carry high risk for dry eye, so avoid it if in moderate and severe dry eye. PRK and SMILE, it's have a moderate and low risk and can be prepared safely in the OSD disease with a femtosecond flap, so it's less nerve endings with minimizing of the suction time. Avoid excessive photoablation energy and use of shield PSS and gentle handling. I think it will be better for cases of dry eye. Post-operative treatment is very important. It is not just a medication. So supportive treatment, it's more and more important, like humidifier, omega-3, as Dr. Ashraf say, moist chamber goggles, scleral contact lens, punctal plugs, and PRP and serum is very, very efficient treatment. So again, we should screen, optimize the surface, choose the procedure, protect, treat post-operatively, and maintain the long term. It's very important strategy for OSD in refractive surgery. And this is, for example, a case of persistent corneal epithelial defect after cross-linking for more than 1 month. And this is 1 week after serum therapy, which is very efficient in cases of persistent corneal ulcer with the stop of all medications that can protect the cornea. Also, dry eye with the surgery, it's very important to careful history and examination for the symptom and signs disease important before surgical procedures. And as a corneal surgeon, I face many cases of persistent epithelial defect in case of OSD, and it's very important thus to optimize the treatment of giving the steroid or the stop or tap the steroid with giving the PRP or the serum therapy in these cases until complete healing of the cornea. Also, dry eye and the contact lens is very important topic. As the primary reason for discontinue of many contact lens users, 30, 40, 50% of the cases, and unsurprisingly, the water content, the thickness, the extended contact lens wear, it's more and more OSD problems. And this is maybe my papers in the Abou about evaluation of the rigid gas permeable contact lens with central fit and the tear film. It's about 70 micron. It's between the contact lens and the cornea, can giving more and more permeability and tear stability. It's more than the soft contact lens. So I think it's multifactorial disease, should be diagnosed and treated very properly. Ocular surface dysfunction can affect the health and the quality of the cornea, and I think the status of ocular surface can have a very high impact on surgical outcome, that ocular surface should be optimized firstly. Thank you so much for your attention, and it gives me so pleasure to be the chief editor of Egyptian Journal of Ophthalmology, so I invite you thus to publish your paper there. Thank you.
Thank you.